Hi, I'm Michelle Sombrano from South Mountain Works Coalition, and we're back with another trauma-informed care and harm reduction video interview. Today, we have Dr. Evelyn Burrell with us. She's the owner of Arise Consultation and Training Services and a licensed psychologist. Thank you so much for joining us today, Dr. Burrell.
Thanks for having me.
Yes.
Hi.
So, I mean, one of the reasons why we wanted to do an interview with you is that you have experience working in the criminal justice system, especially with youth. Can you discuss harm reduction in terms of early intervention with at-risk youth or reducing recidivism?
Absolutely. So most of the work that I do with youth is within the criminal justice system, which means that that substance use is kind of is at the very least a secondary problem, if not the primary issue that kids are presenting with. So what we see when it comes to harm reduction is that when we start to work actively to engage in looking at risk factors, looking at where youths might be receiving any kind of drugs or any kind of substances. Are they at a point mentally, emotionally, physically to start working and actively reduce their drug use, their substance use, and criminality and criminal behaviors? So what we want to do is stop it as soon as we can. We want to come in, we want to be able to intervene, we want to recognize that this person has experienced something really almost abnormal if you think about it. So a child who has been incarcerated is not typical what you would want. And it's definitely not what you would want, but it's also not typical. Most children are never incarcerated. So we have to be really thoughtful about what makes this child so different, the system that they've grown up in, traumas that they may have experienced, what has allowed this particular person to be in the position where now we have to come together kind of as a community and assist them so that as they grow up and they become adults, so that they're healthy, well-rounded, thoughtful, loving, caring adults. So the harm reduction theory, as well as looking into the traumas, engaging the child or the adolescent through their trauma, recognizing their trauma, and not identifying them, I guess, for lack of a better phrase, as a bad kid or conduct disordered or oppositional, but being able to see them and say, this person has experienced hurts that may not be typical or is not typical of an adolescent or of a child. And we need to come in a way that's also not typical, if that makes any sense.
That does. So you're taking really the whole person and the trauma background without offering some kind of diagnosis that would solidify an identity or identify that child with their behavior at that moment.
Well, sometimes you still have to diagnose. But I always consider trauma before anything else. Has this adolescent experienced significant trauma? Is this PTSD? Is this an other specified trauma-related disorder? Is this an adjustment disorder and anxiety that's coming out in a way that is conduct disordered or that's oppositional? And I want to make sure I'm looking at those things first so that that child can get their care, because the diagnosis is going to be based, or the care is going to be based off of the diagnosis. So if I diagnose a child and I say, well, they're oppositional, they're defiant, then the treatment is going to be focused on what that diagnosis is, which is oppositional and defiant, right? If I look at this child and they say, this is trauma, and I give them a diagnosis that indicates trauma, then they're going to in turn receive trauma-informed care. So it's important to make sure that the care that they're receiving and the treatment that they're receiving is consistent with the diagnosis, which means it's really important to make sure that that diagnosis is correct, which means it's really important that we always assess for trauma.
Well, that sounds very nuanced. How does that help with reducing recidivism with youth offenders?
Well, what it allows us to do is really focus on what the issue is at hand. So if I have a child who has been, let's say, physically abused, and they've had a significant history of physical abuse, and then they start to act out physically. So maybe they start getting into fights, maybe they join a gang, maybe they start engaging in drug use to minimize some of their fears or numb them to some degree. And I say, okay, this person experienced significant trauma. I'm seeing hypervigilance. I'm seeing exaggerated startle responses. I'm seeing avoidance behaviors. but I'm also seeing aggression. I'm also seeing depressive kind of symptoms. And in adolescence, depression can come out as aggressively. So depression doesn't show the same in adolescence as we see it in adulthood. So if I'm seeing all of those things and I sit back and I say, okay, this person's been traumatized, then I go to the family and I go to the community as well. And I say, okay, what can we do to maybe teach and train the family that they're coming from? Because if they're young, they might be returning to that home. So then we want to make sure that the household is receiving appropriate care. If they end up in a foster community, if they end up in juvenile corrections, or if they end up in group home setting and they don't go directly to the home, then we need to also make sure that those areas and those organizations are trauma informed so that we're not re-traumatizing this kid. And if they do, again, return home, then now we can go to the family. We can offer family support, family therapy kind of processes, and we pull them back into the community because we recognize that ultimately the goal is that this child isn't incarcerated. Ultimately, the goal is that they can go back home and be well-rounded within their communities. So if we can get the community involved, that becomes a dynamic risk factor.
Mm-hmm.
And then we say, okay, this person they're safe in their school, because their school is trauma informed, and their school has care, their school understands what's going on with this person. The family is recognizing maybe what's going on and why their child is acting the way that they are or responding the way that they are, and now the family has the tools to help manage those things. Maybe this kid starts joining into community programs, sports, leadership, academics, and they start kind of creating and building friendships and creating and building relationships. So as an adult, they've learned how to manage and cope. They've created everything, they've built everything that they need. So when they go into adulthood, there's no need to engage aggressively because they're loved and that they're cared for. And they've learned that it's okay to be angry, it's okay to be hurt, and they have enough of an understanding about what their trauma is, what their triggers are, what their trauma response is, that in adulthood, they can rationalize it, they can make more sense out of it, they can connect those dots, which means they don't have to engage in aggressive or problematic or conduct disordered behaviors. So we've now set them up to be able to be successful because we were trauma informed, because we thought about what their actual need is, versus saying you're conduct disordered, you're a bad kid, you're just going to go to jail and you're going to grow up to be antisocial. We don't want these kids to have that narrative. We want to be able to say what happened to you wasn't okay. And what you did in response to what happened to you isn't healthy for you. It's still not okay. It's not putting you in a situation to be successful. So let's figure out how we can get you to a point where you can actually be successful and happy and well-rounded and caring and part of the community that maybe has seemingly rejected you before.
So you're talking in part about those adverse childhood experiences, or ACE scores, right, which are a static determinant, but combating them or not combating them, but addressing them in a dynamic form with some wraparound services, training, pushing into all these different community spaces where that child travels through with their lifespan. How do you see that? I mean, you've listed a trauma-informed school, a trauma-informed family, a trauma-informed greater community space. How does that begin to shift the community on a broader level to a trauma-informed one, and then start to build out resiliency, a foundation for resiliency?
I think what it allows us to do is see someone differently. When we see someone and we say this person has been hurt and harmed and victimized, we typically become kinder. You ever realize that? So when we have a kid and we say that kid's bad, then we treat them like a bad kid. We become more aggressive, we put them in their place, we are more stern with them, we don't offer the discussion, we say, go to your room, get out of here. And then we become just as rejecting, and we don't show the care and the concern. We're not offering support because we've already dismissed this person. They're dehumanized. They're not even real to us. They're just kind of, a secondary problem. But if I see that same kid for their history, for their past, for the things that they've endured, and I say, wow, this person's been through a lot, and this person's resilient, right? This person's been through a lot and they're here and they're fighting and they're thoughtful. And sometimes they don't, they might have difficulty managing their own emotional process, but we're recognizing them as being emotional and trying to manage their emotional process. And we're just more likely to be thoughtful about it. We're more likely to show care as a community when we say this kid's been through something. And we see it all the time on TV, or when you hear the stories of where people have come from and what they've been through, and we say, oh my goodness, this person is so strong and they're so resilient. And if we can start looking at kids that way, if we can start looking at adolescents that way, they don't become well, now they're just in the system. We sit back and we say, hey, this person is someone that we can align with, that we can stand by, or we can work to keep them safe and help them shift kind of their narrative. So when you speak to ACEs are static. At most, they get worse, right? Your ACE score can worsen, but it doesn't get better. They're static factors. They never change. My ACE score today as an adult is the same as it was when I was 16 years old. Mm-hmm. What can change is how I interpret my world and the world around me. So if I, felt like at 15, I needed to have a gun to keep myself safe, and I was able to go into a neighborhood and join into a family and join into a community that offered me emotional and physical and mental safety, then that mentality starts to go away, right? So maybe I decide to conceal and carry still as an adult, but it's not because of this idea that I'm going to be attacked or hurt. It's because now it's my right to do it. I can, and so I want to, and so I will. Versus I need to keep having a gun on me because I need to be able to get someone before they get me, and that mentality doesn't change. So when we talk about kind of that idea, the scope of recidivism, reducing the harm, joining the community, if we can get the community, the greater community, to be able to sit back and say, this person is resilient, and this person is strong, and this person is cared about, and this person is going to grow to be an adult, a father, a mother, this person is going to kind of continue in their lives. Why not? We would hopefully, I guess maybe in my own world, if it were a perfect world, my own world says that as adults, especially, that we start to look at our adolescents and our children for really who they are, what they've been through, not so much what they're doing. Not sure if that answered your question.
That totally answers the question. So powerful. You hit on so many different areas, and I look forward to seeing you in the live panel with our other interview guests and to elaborate on some of all of these different ideas that you're bringing out, because all of them hit on ACE scores, all of them hit on that trauma-informed care, but I really appreciate the way you broaden it out to the greater community and that compassion that can come forward, and we can really invest in our youth and treat them with love.
Could you imagine?
Could you imagine?
The youths who do receive that, the youths who do receive that treatment, receive that trauma-informed care, do better. They just do better. They have mentors, they have big brothers, they have big sisters, and they learn that adults actually just kind of care, because a lot of them who are having a hard time haven't quite been able they haven't had the opportunity to learn that. And so giving them just the opportunity to learn it is powerful. It's amazing.
Yes. I want to live in that imagined world.
Yeah, me too. I just kind of sit into it in my brain, and, and I think as an adult, as a psychologist, as a parent, how would I want someone to treat my kid if they went through something, and if they had, significant traumas, and if they had high ACEs, how would I want someone else to treat my kid? And so that's kind of how I try to treat theirs and other people's kids, is from, compassion and hope.
Wow. Yeah, 100%. Well, thank you so much. It was a pleasure talking to you.
It was absolutely my pleasure. Thank you.
Yes.